Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most gracious, the most merciful. Dear friends and colleagues, it's a great honor and privilege to participate in this extremely important and prestigious gathering of fellow Africans to discuss the COVID-19 among nephrology population. I had the privilege to work with such distinguished and exquisite group of African professors and physicians to come up with these guidelines. And it was my personal pride that almost 2/3 of these guidelines were adopted from the Egyptian guidelines, which I had the honor to be the head of the committee that wrote the Egyptian guidelines back in Egypt with my two distinguished colleagues, Professor Hussein al-Fishawi and Professor Hisham al-Sayed. Where the three of us worked devotedly in a teamwork fashion to come up with these guidelines. And I was happy when our distinguished colleagues in AFRAN COVID-19 committee chose the transplantation and AKI chapters of the Egyptian Ministry of Health guidelines to be implemented as the African guidelines. Now, if you excuse me, I will share a screen to start my presentation. Okay. Yes. Well, of course, today we're going to speak about the AFRAN guidelines for kidney transplantation population during the COVID-19 pandemic. This is a quick biography. My name is Mohamed Salah Zaki. I'm graduate from Asr Al-Aini Medical School, Faculty of Medicine, Cairo University, 1996. I've got my master's degree in internal medicine in 2000, and I've got my MD degree in internal medicine in 2006. Currently, I'm a professor and head of internal medicine and nephrology department at the National Institute of Urology and Nephrology in Cairo, Egypt. I've got the Board of Nephrology, Egyptian Board of Nephrology in 2005. Now I'm the head of nephrology division in the Supreme Council for Crisis Management of COVID-19 at Egyptian Ministry of Health, member of AFRAN COVID-19 Committee for nephrology population, and co-author of AFRAN guidelines for COVID-19 in renal population, board member of the Scientific Committee for Egyptian Board of Nephrology, and board member of the Egyptian Society of Nephrology and Transplantation, the ESNT, and head of nephrology and kidney transplantation departments at Sheikh Zayed, Ibn Sina, Eden, and Al-Amal Specialized Hospitals, and founder and CEO of Nephro Arab Specialized Kidney Centers. I have nothing to disclose. Our agenda for today will be introduction, epidemiology, kidney transplantation in Africa, AFRAN guidelines, drug interactions, and take-home message. Of course, we all know that coronavirus have 4 subtypes: alpha, beta, gamma, and delta. Among them, beta is the most contagious. Beta usually have a primary host in bats or rodents. This is not the first outbreak caused by coronavirus. We have SARS back in 2002, 2003, started also in China. And we have the Middle East respiratory syndrome, the MERS, which started in Saudi Arabia in 2013. And the intermediate host was the camel. And nowadays, COVID-19, the intermediate host is the pangolin. And there is evidence of direct transmission from bats to humans. Some important dates: the first cases were discovered with outbreak of unusual pneumonia in Wuhan, China, and that was in December 2019. The Chinese ophthalmologist who discovered the first case unfortunately passed away from the same disease. Then the case spread outside China, first one in Thailand, at 13th of January 2020, in the US on the 20th of January, Europe 24th, and the 30th, the WHO declared it as a public health emergency outbreak. 2nd of February, first death outside China and Philippines. 15th of February, first death in Europe. And 14th of February, first case in Africa, found in Egypt, where a lady who came, an Asian lady who came as a tourist, were discovered to have the case, and it transmitted it to around 35 cases by that time. And then Italy had a devastating number of cases, and then US at the 29th of March exceeded that number of Spain and Italy, became the most heavily infected place on the globe. By the 2nd of April, million cases were diagnosed all over the world, and by the 7th of June, the cases reached more than 7 million cases and counting. The structure of coronavirus, we'll have a quick look at it. It is a large pleomorphic spherical particles with surface projection spikes. Its diameter is around 120 nanometer. The envelope of the virus in electron micrographs appeared as distinct pair of electron-dense shells. Those spikes latch onto human cells, then undergo structural change that allows the viral membrane to fuse with the cell membrane. Then the viral genes can then enter the host cells to be copied, producing more viruses. Recent work shows that, like the virus that caused SARS back in 2002, the SARS-CoV-2 also have spikes bind to angiotensin converting enzyme or ACE2 receptors on the human cell surface. This is a diagrammatic photo of the virus. You can see here, these are the nucleocapsid proteins and RNA, and here are the envelope proteins, and then these are the hemagglutinin esterase dimers. These are the spike proteins, and you can see here the membrane proteins again. So, and this is the electron microscopy of the virus, and this is a computer designed photo of the virus based on the electron microscopy findings. As we said, coronaviruses constitute subfamily orthocoronaviridis, and it's an RNA virus with a single-stranded RNA genome and a nucleocapsid of helical symmetry. The genome size of coronaviruses ranges from 27 to 34 kilobases. The largest among RNA viruses at all is the coronavirus. The name coronavirus, as we all know, is derived from the Latin word corona, means crown or halo, which refers to the characteristic appearance reminiscent of a crown or a solar corona around the virion. Mode of transmission, person to person, when persons are in close proximity, less than 6 feet or 2 meters, and the droplets can land in the mouth or nose of the people and then have inhaled into the lung. People are thought to be most contagious when they are most diseased or sick. The sickest, the most contagious, but there's evidence of contagious, that individuals could be contagious even when they are asymptomatic. Spread from contact with contaminated surfaces or objects. And we said the virus is very large. It lands on the surfaces and it remains for a while on different surfaces. And then when you touch the surface and then touch the nose or eye or mouth, you spread the virus. You transmit the virus to yourself. Community spread means people have been infected with the virus in an area, including some who are not sure how or where they became infected. Actually, this happens when there is widespread infection in the community, as what we have now. Symptoms and signs. Reported illnesses have ranged from mild symptoms to severe illness and death for confirmed COVID-19 cases. The most common symptoms are fever, cough, shortness of breath, and we have to know that people may have the virus for 2 to 14 days before having symptoms. And older adults and people who have severe underlying medical conditions like heart or lung diseases or diabetes seem to be at a greater risk for developing more serious complications from COVID-19 illness. In adults, emergency signs, example, dyspnea, persistent pain or pressure in the chest, new confusion or inability to arouse bluish lips or surfaces. Prognosis, the prognosis, most of the cases, almost 70 to 8% of the cases, 70 to 80%, very mild or even asymptomatic cases. In 20 to 30% of cases, they require hospitalization. Among them, 4% of cases might need ICU, and among hospitalized cases, death occurred in around 20 and around 12% of cases of hospitalized cases. Kidney transplantation in Africa, and here are some bad news. End-stage kidney disease in Africa is a growing crisis, where recently published reports has found that most patients in sub-Saharan Africa diagnosed with end-stage kidney disease ultimately discontinue dialysis treatment. As a result, approximately, and take care of the number, 3 million people in this region die each year, not because of starvation, not because of wars, not because of nuclear weapons, not because of any other thing, just because they cannot find proper dialysis, which is a great loss, and it's a devastating figure. And I hope that AFRAN with the African governments will work hardly to elaborate this. Again, in 2017, the entire number of transplants of all organs happened in the world were 140,000. Among them, 90,000 were kidney transplants. So 2/3 of entire organ transplants in the world were kidney transplants. Well, this is the distribution of kidney transplants by regions. Unfortunately, Africa perform out of the 90,000 case kidney transplant per year, only 500 and something cases. And this is something, as we said, 3 million die because they cannot complete dialysis or that cannot find dialysis, neither dialysis nor transplantation. So this number should be also managed. Just I will point to something here, that Eastern Mediterranean, they put Egypt with the Eastern Mediterranean because, you know, Egypt by itself transplant around 1,000 to 1,500 cases per year. So they were not included with Africa. They put all the continent except for Egypt, which I don't know why they put it with Eastern Mediterranean. But if we added the cases in Egypt with those to Africa, Africa will constitute around 2,000 cases of the entire 90,000 cases performed throughout the globe. So, COVID-19 implications for immunosuppression in kidney disease and transplantation. Why we are doing this effort, why we should be concerned about cases with COVID-19, because, as we all know, patients with immunocompromised state due to drugs that we give post-transplant immunosuppression, especially with CNIs, compromise the adaptive T-cell response to a much greater extent than innate immunity, and thus results in an increased risk of uncontrolled viral spreading and invasion. Non-immunosuppressive derivatives of cyclosporine decreased the expression of the N protein of human coronavirus E229E. This multifunctional protein is required for viral replication. And then based on these in vitro data, it might be speculated that cyclosporine could be used as the preferred CNI during the COVID-19 pandemic, but yet there is no data available on whether tacrolimus derivatives or metabolites exhibit similar in vitro activity. COVID-19 mortality hits around 30% in kidney transplant patients who have the COVID-19 infection. This results obtained from the US, where they showed a very high early mortality among kidney transplant recipients with COVID-19, around 28% at 3 weeks, as compared with the reported 1% to 5% mortality among patients with COVID-19 in the general population who have undergone testing in the United States. This mortality rate is also much higher than the reported 8 to 15% mortality in those above 70 years. Can you imagine that the very high risk group without kidney transplantation have better mortality rate than those with kidney transplantation, even if they were younger. So, AFRAN guidelines for kidney transplantation population during COVID-19 pandemic. By analogy with other infectious diseases, it is considered that kidney transplant patients under immunosuppression are at higher risk of poor outcomes, although this has not been proven to date. It is important to note that information about this disease and our understanding of this virus and its impact on transplantation is evolving rapidly, so the guidance may change over time. Epidemiology, initially limited to Wuhan, then infection with coronavirus is being reported from multiple Chinese cities. Recently, rates have been increasing rapidly throughout the entire world. As we said, more than 7 million cases up to now. Mortality appears to be age-dependent, from 90 to 50 to 59. The rate is 1.3, 60 to 69, 3.6, 70 to 79, 8%, and 80 plus years old, the mortality rate is around 15%. Although many patients had comorbidities in the reported series, data on transplant patients is still limited. Nevertheless, the lymphocyte count was lower in those who required ICU care. It is not possible to tell if lymphopenia was a manifestation of a more severe form of disease or if it predisposed to severe disease. Many transplant recipients have medication-induced lymphopenia. Particularly close attention should be paid to transplant patients with suspected or confirmed COVID-19 infection who are lymphopenic. Our recommendations for transplant programs. All transplant-related teams should develop plans to reduce burden on the healthcare system and mitigate against interruption in care of transplant patients. Temporary suspension of the living donor kidney transplant programs should be considered when donation can safely be deferred to a later date. If transplantation is required as a life-saving procedure, it can be conducted with appropriate assessment of infection donor and recipient and with appropriate informed consent. If donors or recipients are suspicious, SARS-CoV-2 should be excluded. Transplant centers. Outpatient clinic visits that are not critical should be either deferred or substituted with telemedicine. Visitors should be restricted as much as possible to transplant floors. Specify team members who may be impacted with suspicious transplant patients. Determine who can work remotely and ensure they have the resources to do so. Develop messaging for candidates and recipients about how and when to contact the transplant center in case of illness, and develop guidance for candidates and recipients about risk mitigation, including limiting exposure to large crowds, hand hygiene, and avoidance of sick exposure. Staff and facilities should be prepared to receive suspicious patients. They should develop guidance for which suspicious transplant recipients need evaluation, testing, and management by transplant centers versus which can remain at home with close remote follow-up. Staff with respiratory symptoms should stay at home. National policies should be applied. Testing of staff should be done according to national and local guidelines. Prevention policies and procedures should be according to national, local, and institutional guidelines. Transplant donors. In case of diagnosis of COVID-19 infection, donor must be excluded from donation at least 3 months. Deferral can be considered unless the need for donation is urgent, when individual consideration should be made with at least 28 days lapse. In case of close contact with a person diagnosed with SARS-CoV-2 infection, the donor shall be excluded from donation for at least 28 days. Donors should be closely monitored for COVID-19 infection. In case of travel to high-risk areas for COVID-19 infection as defined by health authorities, or being a close contact with person traveling from such an area, donor shall be excluded from donation for at least 28 days. If the patient's need for transplant is urgent, SARS-CoV-2 infection must be excluded completely according to Ministry of Health and criteria for both donor and recipient. Donor within 28 days before donation should practice good hygiene according to the WHO recommendations and avoid crowded places and large group gatherings. Transplant recipients. Transplant recipients should avoid traveling, and those transplants with higher incidence of infection are those in contact with COVID-19 infected people or within 14 days prior to the onset of the disease, or those who have history of travel within 14 days, or those in contact with patients who have fever or respiratory symptoms, and they should avoid elective clinic visits. Suspicious transplant recipients should be instructed to call the transplant center and avoid presenting to the clinic without notifying it in advance to avoid inadvertent exposures. They should be examined clinically, laboratory, and radiologically according to national policies to exclude or confirm COVID-19 virus infection. Management of immunosuppressive medications for kidney transplant patients during the COVID-19 pandemic. In case of asymptomatic patients, there is no need for change of immunosuppressive medications. For mild cases, the patient has only mild upper respiratory symptoms, temperature below 38, and does not refer symptoms suggestive of COVID-19 pneumonia, such as dyspnea, persistent chest pain, intensive cough, oxygen saturation is above 95%, and the heart rate, the respiratory rate is below 25 per minute, then with no evidence of pneumonia in CT, then you also, you don't need to do much except for maybe stopping the MPA or azathioprine or mTOR and maintain on dual cyclosporine and steroid therapy. If patient is on dual therapy already, continue the dual therapy. If the patient is on dual therapy, MPA or mTOR plus cyclosporine, then change MPA or mTOR with steroids or replace them with steroids and continue on dual therapy. If the patient is on MPA and mTOR, consider replacing MPA or mTOR with low-dose steroids, and consider CNI dose reduction to the lower bound of the therapeutic range according to the immunological risk if there is no clear improvement over the first 3 to 5 days. If patients with evidence of mild COVID-19 pneumonia with oxygen saturation between 94 to 95%, in room air respiratory rate 25 to 29 per minute, or suspected lesions on CT scan, high-risk patients, then age above 70 or comorbidities, BMI above 30 milliliter kg per square meter, or GFR below 30 milliliter, then stop MPA, azathioprine, mTOR, stop CNI, increase or start steroids 15 to 25 milligram per day. If he is not a high-risk patient, then stop MPA, AZA, mTOR, and maintain on dual therapy CNI and steroids, and always reduce CNI levels to be cyclosporine between 50 plus or minus 15, and TAC3 plus or minus 1 nanogram per ml, and continue steroids in maintenance dose. If starting antiretroviral, lopinavir, or ritonavir treatments, which were thought at the time that they are life-saving, then with those medications, you should stop the CNIs. Yet now there's no evidence that these medications are that useful, so it's not advisable to stop CNI. Patients with more severe COVID-19 pneumonia, oxygen saturation below 94% in room air, respiratory rate above 30, unstable or deteriorating course, or requiring non-invasive ventilation or transfer to the intensive care unit with or without mechanical ventilation, discontinue all drugs, if immunosuppressive drugs, if possible, increase or start steroids at 15 to 25 milligram per day or higher according to local practice. Carefully consider to continue with low-dose CNIs in patients with higher risk of rejection. So the million-dollar question, when to resume immunosuppressive therapy? A proposed approach is to resume the calcineurin inhibitor at half of the previous dosage, starting at least 30 days after clinical resolution, apyrexia, no need for oxygen therapy, etc., negative CT chest, and 2 swabs negative, one at discharge and after 3 days, with the aim of gradually reaching a dose, a level of 3 to 5 nanogram TAC or 200 and 300 nanogram cyclosporine C2 level, a resumption of full dose calcineurin inhibitor dosage, and the maintenance of prednisolone based on clinical judgment after 15 days free of symptoms, and an additional negative swab, case-by-case evaluation, re-initiation of MMF, azathioprine, and mTOR inhibitors can be done. Important drug interaction, there is a possible increase in the exposure of cyclosporine TAC and mTOR inhibitors with chloroquine, hydroxychloroquine. As chloroquine and hydroxychloroquine are given for only 5 to 10 days, it is advisable to follow the trough levels of cyclosporine, tacrolimus, and mTOR inhibitors. In this setting, patients starting antiretroviral drugs that contain ritonavir or cobicistat must stop mTOR inhibitors and CNIs. If the aim is to continue tacrolimus, it should be administered only when blood levels below 5 nanogram per ml, and the dose should not exceed 0.5 milligram overall dose reduction of 1/5 or lower. Cyclosporine also, overall dose should a reduction of 1/5 of lower with level below 50 nanogram. Administration of azathioprine should be accompanied with monitoring of cyclosporine levels. Administration of azithromycin should be accompanied with monitoring of cyclosporine levels closely. There is possibility of rising cyclosporine levels. So according to American Transplant Congress, it's better to not give azithromycin, and can be replaced by levofloxacin. This schedule is a nice one showing the different drugs used in COVID-19 and the different immunosuppressive medications. You can see that a very common thing between all of them when you use hydroxychloroquine is to monitor the QT interval. With lopinavir, ritonavir, darunavir, and darunavir with cobicistat, it's all also, you have major side effects, and you have to measure the therapeutic drug monitoring and leveling of the medication. Unfortunately, with the favipiravir, remdesivir, and tocilizumab, there is no much data. Though with tocilizumab above, if the GFR is above 30, it's safe to be used without any modification. Below 30, there is no solid data about it. Again, I want to remind you to consider a telehealth appointment to avoid any unnecessary exposure. And this is the diagram showing all what we said, triage at home, and then you see if the patient has no symptoms and no exposure, no change. If he has exposure or symptoms suggestive influenza-like illness, and so a patient can be done the high resolution CT chest, laboratory test, and etc., and self-isolation till getting the results. If it is confirmed, referred to COVID hospitals accordingly to be managed as we mentioned. Take-home message: avoid unnecessary exposure and keep social distancing and or self-isolation. When you go out in public, keep away from others who are sick, limit close contact, wash your hands often, avoid crowds as much as possible. During an outbreak in your area, stay home as much as possible. Consider telemedicine, and kidney transplant patients should keep taking their anti-rejection drugs, maintain good hygiene, and follow up recommendations of healthcare team. Thank you. Stay home, stay safe, and thank you to those keeping us safe, and for all medical staff all over the world and in Africa. Thank you and goodbye.